Good afternoon, good evening, good morning, everyone. Um, I'm Ethelene Lomantas, so I'm going to report my part regarding normal flow of electrolytes. So our this is our table on how we made our electrolytes. So on this part, the name of electrolytes, the sodium, potassium, calcium, magnesium, phosphorus, and chloride. And then we also indicate the diagnostic findings for decreased and signs and symptoms for decreased, then the normal values, then diagnostic findings for increased, and then signs and symptoms for increased. So for me, my report is about the sodium. So the electrolyte for sodium, it is to control and regulate volume of body fluids. Diagnostic findings for decreased hyponatremia means increased thirst and antidiuretic hormone release, such as beer potomania syndrome, tea and toast syndrome, but a lot more. And then signs and symptoms for decreased blood pressure, confusion, headache, lethargy, seizures, decreased muscle tone, muscle twitching, and tremors, vomiting, diarrhea, and cramps. And these are the normal values. The normal values between 135 to 145 milliequivalents per liter or millimoles per liter. So hyponatremia is less than 135 milliequivalents per liter or millimoles per liter. Okay, so hypernatremia will be discussed by other members of the group as well as the potassium, calcium, magnesium, phosphorus, and chloride. Okay, then next, pathophysiology of hyponatremia. Hyponatremia means low sodium in the blood or less than 135 milliequivalents per liter, because the normal sodium in the blood is within 135 to 145 milliequivalents per liter. Okay, so to start with, the diagram the common baseline data to know if the patient has electrolyte imbalance is to measure the serum osmolality. A serum osmolality test measures the amount of chemicals dissolved in the liquid part or serum of the blood. Chemicals that affect serum osmolality include sodium, chloride, bicarbonate, proteins, and sugar or glucose. So this test is done on a blood sample taken from a vein. Laboratory value or calculation in milliosmol per kilogram is 2 times sodium plus the glucose divided by 18 as constant plus blood urea nitrogen result divided by 2.8 as constant. Then there are 3 classifications of serum osmolarity. So these are the isotonic, normal, hyponatremia. So it is within 200 milliosmol per liter, or in other books it is within 275 to 300 milliosmols per kilogram. So, and then the second is elevated or hypertonic hyponatremia, more than 280 milliosmoles, or in other books, it's more than 300 milliosmoles per kilogram. Then the third is low, which is hypotonic hyponatremia, which is less than 280 milliosmol or less than 275 milliosmoles per kilogram in other studies. Okay. Then under the normal or isotonic hyponatremia, it's pseudo-hyponatremia. The serum sodium concentration of less than 135 milliequivalents per liter. Then it is also due to hypertriglyceridemia, or increased natural fats, oils in blood, and risk for stroke. Hyperglobulinemia. So these are the IgM, IgA, mga ganun. Due to infection, inflammatory disease, or immune disorders, certain types of cancer. Then hyperlipidemia, mga fats, lipids. And then hyperproteinemia, mga proteins. Ion-specific electrodes has alleviated the laboratory error. Then for the hypertonic hyponatremia, it is due to hyperglycemia, unmeasured effective osmoles, or such as glycine, mannitol, sorbitol, maltose, and radio contrast dyes. This one. Then for the low hypotonic hyponatremia, there are three classifications: the euvolemic hypotonic hyponatremia, hypervolemic hypotonic hyponatremia, then hypovolemic hypotonic hyponatremia. So these are the three classifications of hypotonic hyponatremia. Next, hypovolemic hyponatremia. Okay, so under the hypovolemic hyponatremia, it is the total body water decreases, a state in which the total body water and sodium content are decreased. So these arrows are going down. And the relative decrease in total body sodium is greater than the decrease in total body water. It is a volume depletion, volume contraction, and the low extracellular fluid in the body. So either loss of both salt and water. Furthermore, volume depleted patients exhibit more concentrated urine because the urine osmolality is greater than 400 milliosmoles per kilogram. For adults, the normal urine sodium values are generally 20 milliequivalents per liter in a random urine. So the result depends on how much fluid and sodium or salt you take in. If the urine sodium level is less than 20 milliequivalents per liter. So the causes may be extra renal losses, vomiting, diarrhea, third spacing like burns, pancreatitis, bowel obstruction, trauma, and swelling. If the urine sodium level is greater than 20 milliequivalents per liter, the causes may be renal losses, diuretics, mineralocorticoid deficiency or the aldosterone deficiency, salt-losing nephritis, bicarbonaturia or the renal tubular acidosis, metabolic alkalosis, cerebral salt wasting syndrome, ketonuria, osmotic diuresis. And for the treatment, for hypovolemic hypotonic hyponatremia will be for onset slow, more than 48 hours, administer 0.9 sodium chloride or plain NSS. For onset rapid, within or less than 48 hours, may consider to administer 3% sodium chloride. Stop offending medications, restore intravascular volume with 0.9% sodium chloride or plain NSS or normal saline solution. Then for the hypervolemic, hypervolemic hypotonic hyponatremia, when sodium stores increase inappropriately, or simply meaning, the simple meaning is increased blood volume. Total body water increases as well as the total body sodium increases, going up. And if the urine sodium is greater than 100 milliosmol kilogram, so there are two types. It will depend on the urine sodium level of less than 20 milliequivalents per liter. This may cause due to congestive heart failure, cirrhosis, nephrotic syndrome, low effective arterial blood volume, orthostatic changes in heart rate or blood pressure or hemoconcentration, causes release of antidiuretic hormone and aldosterone. And the treatment for hypervolemic hypotonic hyponatremia will depend if onset slow or more than 48 hours, fluid restriction. If the onset is rapid with less than 48 hours, administer 3% sodium chloride and loop diuretic. Optimize treatment for underlying disease, restrict salt and water intake, and give loop diuretics. And then if the urine sodium level is greater than 20 milliequivalents per liter, the causes may be due to acute or chronic renal failure. So the treatment for this is dialysis. The next is the euvolemic hypotonic hyponatremia. Means normal sodium stores and a total body excess of free water. This occurs in patients who take in excess hypotonic fluids. So in this case, the patient has no edema, just excess hypotonic fluids. And if the urine osmolality is greater than 100 milliosmoles per kilogram, it means inappropriately high. So therefore, the urine sodium level is greater than 20 milliequivalents per liter. And the causes for this may be due to hypothyroidism, or the thyroid stimulating hormone level, glucocorticoid deficiency, or adenocorticotrophin stimulation test, and then syndrome of inappropriate antidiuretic hormone, and then stress, and then drugs. And then it can also be due to severe euvolemic hypotonic hyponatremia. So for the severe euvolemic hypotonic hyponatremia, the serum sodium level is less than 125 milliequivalents per liter. Then, if the patient is symptomatic, showing symptoms of confusion, ataxia, seizures, obtundation, coma, respiratory depression, acute 48 acute it is acute, meaning within 48 hours. So the treatment will be 3% sodium chloride, 1 to 2 ml per kilogram per hour until symptoms resolve. Then administer 0.5 ml per kilogram per hour. Sodium should not increase any faster than 12 milliequivalents per liter in first 24 hours, or 20 milliequivalents per liter in the first 48 hours. Stop 3% sodium chloride as soon as medical possible, or doctor's order. And then water restriction, 3% sodium chloride plus loop diuretic. Stop offending medications, hormone replacement. If urine milliosmoles is greater than 300, a loop diuretic may be needed to enhance water excretion. So the sum of urinary cations is urine sodium plus urine potassium should be less than the concentration of the infused sodium to ensure excretion electrolytes free water. Okay. If for the severe euvolemic hypotonic hyponatremia and the patient is symptomatic and then chronic for more than 48 hours, the treatment will be 3% sodium chloride, 1 to 2 ml per kilogram per hour. Change to water restriction after 10% or 10 milliequivalents per liter. Increase in serum sodium or symptoms resolved. Maximum correction of 50 milliequivalents per day. Water restriction, 3% sodium chloride plus loop diuretic. Stop offending medications, hormone replacement. Patients with chronic hyponatremia are at higher risk for severe side effects if serum sodium is corrected too rapidly. So there should be close monitoring to the patient. Then the sum of urinary cations, urine sodium level plus the urine potassium level should be less than the concentration of the infused sodium to ensure excretion of electrolyte-free water. And if it cannot be resolved, there will be long-term management. So for the long-term management, it is to identify and treat reversible cause. Then there should be water restriction, administer furosemide with 2 to 3 grams of sodium chloride per day. Give the meclocycline 1,200 milligrams on day 1, then 300 to 600 milligrams twice a day. Avoid if renal or hepatic insufficiency. Then the urea is 15 to 60 grams per day. Okay, and for the severe euvolemic hypotonic hyponatremia, there is also asymptomatic. So if the patient is asymptomatic or mild symptoms like headache, lethargy, and dizziness, it is due to chronic or rarely less than 48 hours. So no immediate correction needed. But if cannot be corrected, there will be long-term management. So it needs to identify and treat reversible cause. There will be water restriction, administer furosemide with 2 to 3 grams of sodium chloride per day. Give the meclocycline 1,200 milligrams on day 1, then 300 to 600 milligrams twice a day, and avoid if renal or hepatic insufficiency. Then urea is 15 to 60 grams per day. Then for the going up, for the euvolemic hypotonic hyponatremia and the urine osmolality is less than 100 millimoles. Milliosmoles, less than 100 milliosmoles per kilogram, maximally dilute, appropriately low. So therefore, the urine sodium is less than 20 milliequivalents per liter. Causes: primary polydipsia, psychogenic polydipsia, low solute intake, or such as beer potomania syndrome, heavy alcoholic drinkers, or tea and toast syndrome. Then the treatment is simply fluid restriction. That's all. Thank you for listening and thank you for watching.